back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today we're with our favorite trauma doc. How you doing, Mark?
I'm doing well, thanks, Dennis. Good to be here.
So let's just jump into it. So what I'd like to know is, how do I optimize my patient for surgery? And so what we'll do is same question, but two different scenarios, two different contexts. What do I need to take into account when I'm making my decision whether this patient coming to me, or maybe I've been holding on to them, if they're too sick or they're well enough to go and do either a big debridement or a big surgery?
Right. One of my professors, he once used to say, when determining if a patient needs surgery, you have to ask, do they need surgery? What incision are you going to make, and what are you likely to find? And I think that works great, in your roll threes where you have all kinds of capabilities available. But before you make that decision, you have to figure out what are they likely to survive when it comes to, the austere type of environments that your medics and you work in. And so if you cannot get the patient to a place where they can get some type of definitive control of bleeding, or correction of whatever is making them as critically ill as there is, it may not be the best use of resources. And so it is not uncommon from time to time to hear about some heroic measures that were made in an austere condition only for the patient to die later when they got to either a roll 2 or a roll 3, meaning somebody heroically did a thoracotomy, clamped the aorta, they got control of their airway, but after an hour ride to some type of definitive or more resource-rich place, they unclamp the aorta, the patient dies immediately. And so these are the things we want to stay away from if possible. And so who are the candidates for an operation? And I think the first thing is to figure out is, when can you get to something a little more definitive, and who's going to be taking over the patient's care the rest of the way. So the extreme might be your JMOWs, where they descend upon a patient in the most austere of environments and whisk them away. And I think they kind of get carte blanche because they know exactly what they have and where they're going to, and it's a very streamlined way of caring for that patient. But what about the 18 Delta that rolls up after an IED or a bad patrol, something like that, and your patient has been cared for in the worst of environments? They're cold, they're probably coagulopathic, they're in hemorrhagic shock, maybe on the borders of septic shock. Can this patient endure an operation? Well, it depends what that operation would be. An amputation, probably, right? A massive debridement, maybe not. A massive debridement, could bring on a fair amount of phlebotomy in the form of coming across vessels in a coagulopathic situation where you can't control all the bleeding. And so this would not be one. And then a patient who's under resuscitated without blood products, that is a big, big problem. And these are the patients we want to avoid taking to the operating room, period. So that being said, once you're in the operating room, that's not necessarily a place for anesthesia to catch up. I come across that from time to time when I'm taking some other folks, some other surgeons who are placed in an austere environment, and they get the patient to the operating room, and they're waiting for the go-ahead by anesthesia while the patient's bleeding. That's not the right answer. The only way to stop the bleeding is for the surgeon to move forward and get control of what's bleeding. And then once you have hemorrhagic control, then anesthesia can potentially, quote unquote, catch up.
Yeah, and that can be, I'm sure, a challenge in itself, considering how drugs affect differently in patients with, bad hemodynamics and things like that.
Sure. Yeah, bad cardiac output. And bad cardiac output, you're not going to circulate the drugs. Hyperdynamic, these drugs, they may even chew through those drugs quite quickly. And it is not going to be a well-balanced anesthesia and surgical effort. It's going to be ugly. It's going to be unpleasant. But that being said, we've talked about this in our PFC courses. Pain's bad. You want to control pain as much as you can, but the pain itself shouldn't kill somebody. The pain itself, although we don't welcome it or approve of it, you got to get to the bleeding. And once you stop the bleeding, then you can, take a pause and try and anesthetize them or give some form of analgesia to get them through the next step in the resuscitative and surgical phase.
You mentioned time a few times. I guess is there an upper limit? I mean, does it have more to do with the patient, or is there a time period that lapses where it's like it's not even worth it?
Well, so no, there's not a certain minute that I can think of if I understand your question correctly. We know you much better than I do that sometimes our efforts at surgery and resuscitation are no longer done for the patient themselves, but for the morale of the team, the morale of the village, and so forth. And so, despite some poor outcomes, we need to continue the resuscitation or even the surgery to further our efforts either in the mission itself or the morale of the team. That being said, from a pure surgical standpoint, it's my opinion that you keep going until the patient declares himself. That's not to say you operate needlessly on a patient that could benefit from some resuscitation, some permissive hypotension, things like that. Those are the things. Those are the issues we want to weed out during today's discussion. But there is value in pushing forward when it may seem like you're not effectively treating the patient. You just don't know. Just like when you train or you go through selection and so forth, you just don't give up until the bell is rung, the whistle's blown. Whatever analogy you want to use. If you have that patient's life in your hands, don't stop trying. I don't. There's a point when the heart gives out and the patient's asystole, they don't have a pulse, there's no effort to breathe, there are no neurologic signs. When you're in an austere environment, you don't have the luxuries of all these fancy monitors. You don't know, when that patient's body is going to quit. And when working on, a special operations team member, their physiology is much different and can tolerate much more than the average person.
You mentioned making sure you get control of the bleeding. Definitely understood. Let's say we have been able to control the bleeding. It's just that he's very shocky. He's cold, and we're making some headway. We've given our a unit of blood. We have our little HPMK on him, but he's still shocky. He's still cold. Is this something that you're going to want to fix first, or do you want to at least take them into surgery and get definitive control of that hemorrhage?
I guess it depends on what the injury itself really is, right? There's surgical bleeding, and then there's active blood loss from unnamed vessels, for instance, right? So surgical bleeding means usually it's a named vessel, and the bleeding is ongoing and it can be identified readily, versus, say, large surface areas that are bleeding that there is no surgery you can do. Now, what do those look like? Those often look like where areas of the body are denuded, meaning super bad abrasions where the muscles exposed, some bones exposed, and it's bleeding and bleeding and bleeding. Or scalp injuries where you can lose tremendous amounts of blood, but there's no named vessel. They're just the face and the neck are so well vascularized. These areas can bleed and bleed and bleed. And we've all seen, or at least many of us, your listeners have seen, where arteries, big and small, have stopped bleeding, only to bleed later when the patient's either rewarmed or they're no longer in spasm. And so the named and unnamed vessels can do that based on the type of injury. So the blood loss from large exposed areas of smaller blood vessels that you can lose tremendous amount of blood, generally direct pressure is going to be the answer for that. Some of our topical hemostatic agents are excellent at doing that as long as the patient is not coagulopathic. Versus the patient with larger vessels, larger named vessels, these need surgical control. They need it as soon as possible, because when that patient is prepped and ready for the operation, and sometimes just before, they will open up. The spasm will stop. These are typical of arteries, right? Arteries are much more muscular. When the spasm is over, these will bleed. And then when you warm the patient up and they vasodilate, they'll bleed from that as well. So surgical control of these is absolutely imperative. And surgical control just basically means you're clamping or tying something off. This is not the time to do bypasses and so forth. This is just the time to get some type of control.
Right. Hence damage control surgery.
Hence damage control surgery. And just a short plug and some concepts here, antibiotics. So when you have these large massive wounds, it is important to get antibiotics on early. The sepsis can kill them late. We're all aware of that. But also understand that you're probably underdosing these antibiotics when you give them to these patients. Their volume of distribution is dramatically changed. The circulation has dramatically changed. They're going to lose the concentration of antibiotics as they start bleeding again. And so it's not atypical to dose these patients 2 to 3 times higher during these periods of stress and blood loss.
Okay.
And getting those antibiotics on early will make a difference, not immediately, but certainly in the mid to long term range.
So, kind of same situation as far as we want to take somebody to surgery, but it's very austere. Very right. Limited resources. Help is quite a ways away, right? So we're kind of faced with: do we do this or we do not do this? What other things, other than just stability of the patient, what other things do we need to take into consideration?
Certainly. So it really comes down to March, right? Mm-hmm. And so the blood loss, making sure that the airway is, we nearly exhausted our discussion on blood loss for now.
Yeah.
So ventilation is important, obviously. Now, if the patients, when I talk about ventilation, I don't mean just CO2. I mean just gas delivery and removal. So, so it's okay for your patient to be hypercarbic. What we're talking about is regulating their pH so that they can maintain a blood pressure. What we're talking about is maintaining some degree of gas exchange at the cellular level, since that is what defines shock, and so having some form of definitive airway if you're thinking of taking your patient to the operating room is key. Now, that definitive airway doesn't necessarily mean a tracheostomy. It just could mean that you have a bag valve mask and you're able to maintain that airway, say with ketamine versus a narcotic, a traditional narcotic like fentanyl or potentially morphine. We try and stay away from morphine in our bleeding patients, just due to its histamine release and potential to cause hypotension, which is very confusing in your hemorrhagic shock patient. Fentanyl doesn't do that, certainly not to that degree.
Mm-hmm.
So the airway, and then we talked a little bit about temperature and making sure that our patient is as close to euthermic as possible. Are there protective mechanisms in your patient who's hypothermic? Well, if they're really, really, really super cold, yes. But if they're just cold, no, that's not protective and not helpful. And so there's issues with potassium, for instance, with hypothermia. As potassium goes down when they're cold and they get rewarmed, potassium levels rise. So there's some metabolic issues that you'd like to optimize. So, in brief, we hit control of hemorrhage. We're talking about a definitive airway of some sort, and then some of the metabolic issues that we can encounter, keeping our patient from being too acidemic actually, and so they can tolerate an anesthetic for surgery, whether that surgery be a debridement, removing some obvious foreign bodies from an IED, for instance, or a bad gunshot wound, or some type of improvised weapon that's covered in stool that they're impaled with. All of these patients warrant some type of surgery if they can get the surgery they need and then the place they need to recover, because the surgery itself is not always that elegant, but getting the patient through the surgery and getting through their injuries, that's really what this is all about.
Mm-hmm.
And that takes a lot of skill, a lot of resources, a lot of knowledge, and a ton of care.
Right.
A ton of will.
I mean, to be honest, think about some of the surgeries that we've been trained on. It's like hard to even fathom what really resources do you need. I guess, how much blood do I need? I understand, I need a scalpel, I need some clamps, some suture material, that stuff, that's pretty easy. But as far as like all the, how much oxygen do you need? How much drugs do you need? Blood products, et cetera, et cetera. I mean, those things add up really quick. And like, is there any kind of go by as far as, how do you even prepare?
Well, I hate to do this to you, Dennis, but I'm going to put it back on you. I mean, the reason why there's an 18 Delta and a 6-day whiskey and a 6-day whiskey 1 is because you're trained to see and deal with this. And the reason why there's a battalion surgeon is because, they've seen a lot and been through a lot, and they have some experience as well. And sometimes it's just a hard call.
Uh-huh.
It's, this one's going to be expectant. and taking the burden off of the medic or the first responder, if you will, because how do you have lunch and breakfast and go through basic or SEER school with somebody and then say we're done? I can't imagine making that call. And sometimes that's the onus of, a higher echelon to say, look, enough's enough. We've got, multiple patrols left and there's only so much blood in our refrigerator that we can send you. Do your best.
Right.
So I don't know, Dennis. You guys who live this every day have an inkling, and even at that, there is some emotion that's tied to it. And you and I are surrounded by these anecdotal cases of somebody going through 200 some units of blood and lived.
Mm-hmm.
And yet there was somebody who, physiologically was an equal to that person, and they didn't get that blood. Right. And maybe their injuries were as bad. Maybe they weren't nearly as bad. But all the effort went into that one soldier, kind of like we were talking about earlier. There's some things about life that are just plain unfair. And so deciding whether this is an aortic injury or a caval injury, what's bleeding inside the box, those are things that you can't necessarily do. But if you look at how quickly they deteriorate, or you look at some of the things that happen when you change their physiology, that'll give you another data point as to whether you call it or you push forward. So your patient who seemingly has a blunt injury, who's hypotensive, lift their legs up, give them a double transfusion, right?
Right.
And if they respond to it and they stay stable, they're going to be abnormal but stable. Abnormal. That's the person I would push through. But if you give them a double leg lift and they transiently become, I don't want to say normotensive, but their physiology improves. Maybe their heart rate goes down and their blood pressure goes up, but then it falls again and their legs are still up. This may be a patient you may want to call early. Yep. and make them expectant while somebody else, can afford a bigger resuscitation.
Right. Yep. And that's what telemedicine is for. And it's definitely not something that's really trained, I don't think, very well. Like, it's definitely gone over and there's classes on it. But nothing really prepares you for that decision. And, that's why you need to, I think, reach out to your docs, reach out to telemedicine to help have somebody who's separated from the situation, tell you, hey, this is what you're going to have to do. Because, we don't train to lose. Everything is win constantly. And it's very hard to kind of flip that switch to say, no, this one, I'm okay to lose. That's not in our DNA. So I would definitely suggest, reaching out to somebody like Mark, who has done this day in and day out, making those life-changing decisions for some kind of expert guidance.
I was with some folks earlier this week, and I think there's a lot in what you said, and there's a lot in what you didn't say. And living with that guilt, this is a slight offshoot of our topic here, but living with the guilt, feeling that you have sentenced your patient to life or death, meaning you realize that they're expectant and there's nothing left you can do, has taken an immense toll on all soldiers. And I think having that person, whether it's the battalion surgeon or, somebody higher than you, help you make that decision that enough's enough. I hope from a psychological standpoint, our good folks who are doing all of these things understand that it's not, they didn't fail.
Yeah.
It may feel like a failure because they just lost a brother or a teammate, but that's not necessarily their failure. It's just bad situation. So I don't want to get off topic, but in part it is on topic in that you're going to lose some folks, and it's going to hurt, and it's that hurt that drives you guys to do better, to learn more, so that the next one doesn't have to be lost. But this is the cruel world we're in, and the cruel world we're fighting for. So share that burden.
Yeah. Well, it got dark really quick. So let's try and shine some more light on this. If we can kind of summarize what we talked about, receiving a patient, you're going to have to look at what are their injuries, what resources do we have, how long until we can get them out, if you can get them out at all. Just to kind of get your arms wrapped around, okay, is this possible or not?
So let's
okay.
It is, yeah. Let's also look at it a different way, because I think we're trying to simplify this, and I don't know that I necessarily simplified it. Injuries to the chest, okay? Mm-hmm. Injuries to the chest, those are often more lethal, at least more acutely lethal than injuries to the abdomen, which can be more acutely lethal than injuries to the extremities. Okay, so if you're looking for a quick and dirty, think of it that way. Through and through, unilateral chest injuries, injuries to the lung. Mm-hmm. The farther they're out from the mediastinum, the more likely the patient can survive. Right. Mm-hmm. So if you somebody gets shot through the chest, and it's a single gunshot wound, which we may or may not know, but if it's a through and through hole in the lateral part of the chest, or even if it's a one hole in the lateral part of the chest, the patient has a reasonable chance to survive. In other words, it's I don't want to say rare, but not all patients with a hemothorax need surgery. And so think of it that way versus the mediastinum, right dead center in the chest, but beneath the sternum or at the base of the neck. These tend to be lethal. Right. And these are the ones that I would say, okay, you're going to give a go at it, and you're going to do it for a short period of time. Okay. The amputations, the reason why our soldiers are surviving these are tourniquets. So that buys you a lot of time, and they may lose parts of their limb. They may lose their hands and wrists and elbows and so forth, and even shoulders, but they can make it. And so these are the patients that you may not consider going to the operating room, but just kind of keeping them warm and keeping them prepared, versus the gunshot wound or the blast injury directly to the chest or neck. The abdomen is truly unknown. There is so much going on in the abdomen. It's kind of like the neck, but there's a lot more space. You don't always have to operate immediately on the abdomen, but I don't know that it can wait, a period of days. And you may not even be able to wait for a period of hours. If it's a bad colon injury, that sepsis is gonna set in, and the patient's gonna declare themselves one way or the other. And you can't really, other than a JMOW, I don't expect a medic to do a laparotomy and resect liver and colon and so forth. They may be able to tie off the colon, which is not an unreasonable expectation, at least for the 18 deltas that I've had the honor of working with, and be able to decrease the amount of contamination. Right, that's the second principle in right. doing these laparotomies for trauma. The first being control bleeding. So that's not an unreasonable expectation for an 18 delta who knows that there's going to be somebody on the receiving end in a short period of time for that patient. So I just wanted to provide a little bit of clarity, a little, a type of barometer for who they might be able to predict needs an operation or not.
Right.
And I probably should have brought that point early in this, but through the magic of radio, you can edit that into the right spot.
Too easy. So, as far as going through deciding who should get it, who should not get it, resources wise. And then when it comes time to, we have the resources, this person's a good candidate, just making sure they're optimized, I guess, to the best of your ability, hemodynamically, temperature, anything that you can do to kind of roll back that lethal triad to the best of your ability and the time available. Because if you're having to chase down bleeders and things like that, you really don't have a lot of time.
And drain.
Yeah.
If possible.
Okay. Is there any other things we need to consider? Because this is a pretty complicated topic and it's a podcast,
It is. I think we've opened Pandora's box to probably more things to talk about and how they interrelate. But I think I don't, my thumbnail sketch of what we are going to talk about and kind of coming up with ideas. I think we've hit the major topics. And unfortunately, a lot of it is just boots on the ground and the emphasis you made on telecom.
Mm-hmm. Yep. Well, cool. Well, thank you very much, Mark.
Thank you, Dennis. Always a pleasure.
That's it for today's podcast. Be sure to go to our website, www.prolongedfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy is waiting there for you.